Hey, Chris.
Objectives, like for instance, the relational factors in treatment and co-occurring conditions such as substance use and eating disorders, those we'll address in our upcoming sessions in our series. Next slide. We'll be offering this series weekly on Wednesdays from 12 to 1 p.m. Central Time. And next slide, please. We hope you join us for those talks. And if you wish to obtain CEU credits, we've sent you some information via email about how to generate your certificate. If you need a certificate of completion, and you're not a psychologist or social worker, we are happy to also create a certificate. Please just let us know. Next slide. And we want to give a big thank you to the Wounded Warrior Project, a nonprofit organization dedicated to supporting post 9/11 veterans and service members through mental health care, rehabilitation, and community programming. And we also want to give a big thank you to the Road Home program at Rush University Medical Center, which provides free evidence-based mental health care for veterans, service members, and their families, including weekly outpatient services, as well as accelerated 1 and 2 week programs offered both virtually and in person. We're grateful for their support in making this series possible. Let's go ahead and get started, and I'll hand this over to Dr. Sheila Dugan and Dr. Carla Wente to discuss their talk.
Well, good afternoon or good morning or wherever you are. It's lovely to be here today. My name is Sheila Dugan. My pronouns are she and her, and I come from a tribe of physical medicine and rehabilitation, which is a special type of physician that focuses on function through the lens of pain, disability. Many PM&R physicians in the VA system take care of specific injuries like a spinal cord injury or brain injury or an amputee, but it's really wonderful to be a pelvic and abdominal health physician working with veterans. And I've had the pleasure and honor of being a part of the Road Home since we started, originally starting with MST cohorts and allowing them the opportunity to learn more about their pelvic and abdominal health. But nowadays, combat veterans, anyone who comes our way, gets the opportunity to actually learn more about some of the physical manifestations of the amazing things that they have done for our country and for each other, as well as the other side, the military sexual trauma side of their time in service for us. I am really thrilled this year to include my colleague, Carla Wente. Dr. Wente is a PhD level physical therapist who has spent a lot of time thinking about pelvic and abdominal health, and I'm going to ask her just to say hello and just say a few things about herself. Thanks.
Thank you. Yeah, so Dr. Dugan mentioned I recently completed my PhD in health sciences. Dr. Dugan was lovingly my advisor for that. And so I mostly study pelvic floor dysfunction, women's health, midlife women's health, things like that. But I am a pelvic floor physical therapist, and I've been practicing for 13 years now. So I'm really excited to be here to do this talk today.
Yeah, and just a few other quick things to say that neither one of us have anything to any conflicts of interest. We will be talking about things oftentimes from a specific gender, but we take care of all genders, and we welcome all individuals that need our evaluation and care. And then lastly, some of our conversation might be upsetting or triggering, so just want to remind folks that we have the support to help people that have some triggers. If you need to take a break, if you need to leave the meeting, we understand that. And if you need to reach out for help, we would hope that you have your own sources of help or can always get to the emergency department. So just want to say thank you for having us. And Carla, let's begin our conversation. And we do want it to be a conversation because we are here to empower folks for their own health, for the health of their clients or their family member, to really kind of start thinking about some of the modifiable things that we can help with, looking at the link between trauma and the pelvic floor, understand how what we would claim as pelvic floor dysfunction presents clinically after trauma. And oftentimes my veterans will say, you know, I had this feeling that ever since this happened to me, this is what's been going on. But sometimes in Western medicine, testing is done that comes up as normal, but yet there is this dysfunction. So just to sort of affirm that this is the case, we'll kind of use a case of pelvic floor dysfunction in a female veteran who had MST as a way to help you understand the way we listen and prepare and then examine and then make a plan of treatment. And a big part of that plan is the role of pelvic health physical therapy. And again, you know, ironically, I myself was a physical therapist in the 1980s and then went back to med school in the 90s. So I have this love relationship with my physical therapy colleagues because it's nice for them to also have a physician who kind of gets what they do. And I remember when I was a physical therapist calling a physician who was sort of like, I don't know what you're talking about, so I really can't add to the care of the patient. So we'll have about half of our time talking about pelvic health physical therapy. In my more than 10 years now working with veterans, more and more we have pelvic therapists in the VAs, which is really fantastic. But if not, definitely from community health perspective, we have pelvic floor therapists across our country and really across the world. It is a established specialty, and actually Dr. Wente is going to be spending her career learning more about what is pelvic therapy, what's the right way to do it, and what are outcomes. So we're excited to see her early on now in her career to bring the science of what we're doing. There's also medical management that myself as a physical medicine or rehab provider would be able to add. And oftentimes, of course, we work with organ doctors, urologists, gynecologists, gastroenterologists, given the sort of manifestations and urination and bowel movements and stomach upset, et cetera. And we really believe in interdisciplinary care and patient communication. And quite honestly, it has also been an incredible privilege to work at a place with behavioral health physicians who are so knowledgeable about PTSD, who are also creating the science behind really effective management of PTSD. So I just want to also give a shout out to all of my my colleagues here at Rush and beyond in the behavioral health world, as well as everybody at the Road Home and the Wounded Warriors, which has helped lifted up this this messaging about pelvic health. So we'll get started from here, and any questions you might have, please throw them into the chat so that we can answer at the time. Sometimes if you're looking at, let's say, a diagram, if you have a question, you know, throw your question in the chat, and we were happy to open up. Dr. Wente, you're on.
All right. So we are going to talk about the pelvic floor muscles, and it's okay if you don't know much about the pelvic floor muscles, because I think most of us don't. We don't talk about this a lot, sort of just in our baseline educations. So I think it's really important to look at these structures and think about how they're positioned and what their role is and function. So we're going to talk about that. So the first, we talk about the 4 S's of what the pelvic floor muscles do. And so the first S is support. And so you can see in this sort of side view how the pelvic floor muscles are acting like a bowl, or kind of the bottom of the container for the rectum in the back, the uterus in this case, and then the bladder in the front. And again, like, just to reiterate, I can only fit so many pictures on a slide, but myself and Dr. Dugan and the majority of pelvic health providers, we see all genders. So again, this could have easily been a male anatomy picture, and it would be the same muscles. So in addition to supporting our organs, the muscles also provide stability to the bony structures and ligamentous structures. So this picture shows kind of a top view down into that bowl of the pelvis. And you can see how if we didn't have these muscles, we'd have a big hole in the bottom of our pelvis, right? And so this helps to provide support to our spine, our hips, our abdominal wall, and connects all the way up to the diaphragm as well. This is what we might know the most about the pelvic floor muscles, is that they provide a sphincteric and sexual role. So I snuck another S in here. But you can see from this picture, this is kind of that like view of the perineum. And again, now this one I've included, luckily, male and female anatomy. You can see how the muscles wrap around the openings and the sexual organs. So I don't know, can you see my cursor at all or no? You can, okay. Okay, so you can see like in this picture, the pelvic floor muscles, again, are this grouping of muscles. Some go around the anus, some go around the penis in this case, or around the clitoris, around the urethra. And sphincteric, again, means like they can assist with closing and opening. And then they also provide support to these sexual organs. All right. So you can start to think about how if there's a dysfunction in these muscles, what might happen based on just like that brief anatomy and function. So Dr. Dugan, over to you.
Thank you very much, Carla. So I think that in your work as a practitioner, if you're on the call, one of our behavioral health folks or a social worker, or as a client, a patient, this idea that we can link trauma to our bodily system, our ears go to our shoulders, we have a clenching in our stomach. Let's talk a little bit about the pelvic floor muscles and their own kind of unique contribution to trauma. So this idea of the flight, fight, or freeze happens through what's called the autonomic nervous system and the sympathetic system in particular. And, at the moment of trauma, you might perceive again the heart rate, the blood pressure, you're sweating, shaking. If someone looked at you, your pupils would open so you could sort of take in your environment. But then blood gets shunted away from the sphincters because, again, sort of bodily functions become less meaningful. If there's a tiger charging at you, you need to get your blood to your legs and get the heck out of there, right? And also, there's this increased sphincter tone, which at the moment, again, is part of this natural response. And I would say the more intense the environment, the more intense the trauma, the more these behaviors start to become your new normal. And I don't know that we talk a lot about sphincter control when we are, I guess, sort of coming back after things happen. And I will stay sort of in that physical place because today we're talking about the pelvic floor, but really, again, want to give a big shout out to the work that you're doing with your therapist. So for instance, if I see a veteran who's here for the outpatient program for PTSD, they're already bringing skills that come from their behavioral health visits to think about, am I taking a deep breath and am I relaxing? So we're going to sort of broaden the conversation to include what's happening, I guess, below the belt, if you will. Okay, Carla, next slide. Thank you. So again, pelvic floor specifically, we have this picture on the right here, which sort of tells us the area that we're talking about. And there has been some additional work done. And again, as I mentioned earlier, this sort of triggering phenomenon is something that reinforces the tension. So there are some studies taking a look at, increasing tension in these muscles in subjects that were viewing traumatic images. That pelvic floor muscle overactivity is greatest in those with trauma leading to PTSD. So we can compare, sort of what version of PTSD do we have and how do we link that to pelvic floor muscle? And it's definitely a mediator to the development of sexual dysfunction in childhood victims of rape and sexual assault. And I think, we all know that we do have veterans that come with ACEs or adverse childhood, experiences that can then be sort of furthered, if you will, given an MST, and that gastro and urinary symptoms are common in responses after trauma. And as Carla so elegantly showed us with her pictures, that these sphincters aren't opening, or that there's this sort of extra stability reaction, if you will, that doesn't really bode well when we have to sort of stop and relax and find a safe and quiet place to finally empty the contents of our bladder and our bowel. And then lastly, depression and anxiety are directly associated with bowel, bladder, and sexual dysfunction, on top of the depression and anxiety and, PTSD symptoms that the veteran's already having. So just sort of piling on, if you will. And these are all studies from the last 5 years or so. Thanks, Carla. That's great. Next slide then, yeah. So overactivity of the pelvic floor muscles, what are the kind of common things that you might hear your clients talking about that might perk your attention? This might be a pelvic floor issue, rather than thinking, oh, of course, folks in the military that have MST have trouble going to the bathroom, as though it's just a given thing that can't be changed. If it's pelvic floor dysfunction, it's more likely going to lean towards incomplete emptying, perhaps the idea that you have to actually stop and empty your bladder again before you get up, or put your underwear back on and go back to your duty. Because if you don't, you're going to end up leaking this extra urine into your undergarments. When we do ultrasounds in the office to understand if people have a lot of retention of urine, you never completely empty your bladder. I think of it as more like a brown paper bag that has sort of, if you crunched it up, there would be like folds at the bottom, rather than the bladder is some nice smooth balloon. So we never completely empty, but we typically functionally stop, relax, open our sphincter, and then empty the urine out, and then go on about until the next time that urine builds up, rather than having it become incontinent or leaking out. And sometimes people end up going to the bathroom a lot because of this kind of concern that if I wait and let it leak again, I'm going to be in the middle of something else and it's going to be embarrassing or a problem. So then you start to think, let me just in case empty my bladder. And then you end up, having more frequency of urination. Sometimes it becomes really painful. I'm going to hang on to my urine because I need to, but now it's really causing me discomfort, which again then helps with this cycle of fight and flight, and your muscles don't relax, so you don't completely empty. So you can see I'm describing kind of a vicious cycle, if you will. And just calling attention to that, Carla will talk a little bit about sort of bladder diaries and retraining. Same thing when it comes to bowels. Constipation is common, not completely emptying, and so then you end up with some extra stool or streaking in your underwear. When it's time, you need to hold on to your bowels. And let me tell you, talking to our combat veterans and the amount of time they have to divert themselves from being able to empty their bowels, building up this kind of urgency, it's pretty remarkable. And then if things aren't completely relaxing, then you have painful defecation, which then feeds back to that fight or flight. Like, I can't relax to go, so then you become more constipated. So again, recognizing what is your new baseline, what does it mean to us as muscle and function doctors, and same in sexual dysfunction, the idea that you relax and blood flows and you're feeling really confident and comfortable, versus that's not what's happening. You're not having a full vasomotor reaction. So then things are dry, they're uncomfortable. You don't have the same erection as you usually have. There's this idea of performance anxiety. There's your partner feels uncomfortable. And so then that sort of becomes the new normal there. And then just chronic abdominal, back, hip, and pelvic pain. And this is these are the things that we are listening for carefully. And if you're a behavioral health provider or a social worker, you may not be getting in the weeds like we will, but you will be able to think, aha, this is sounding like a pelvic floor dysfunction, and maybe I need to sort of remember what should I do about that, which is hopefully when you leave the meeting today, you'll be feeling action oriented to send people for an evaluation and care. Okay, thanks, Carla, for this great reference from 2025. Okay, we thought it'd be helpful to give us a patient to help us kind of in our mind's eye understand what we're talking about. This may relate to somebody that you cared for, that you know. It might feel like yourself. This is a female veteran that presented to me in physical medicine and rehabilitation who had a childhood sexual assault history and then military sexual trauma. And many times, the evaluation after the trauma or other workup you need causes additional medical trauma. Are we really giving you the time and space to consent to treatment? Are the testing really uncomfortable? A lot of scopes into the penis, into the colon, pretty traumatic things for anybody, but especially when you have a pertinent trauma history. Are people telling you this might cause a trigger? Let me know if I'm doing okay. Let me know if we need to, take a break and either not do this today or reschedule or take it slow. And let me ask you, what are some things that you can do to help relax so that as we're doing the assessment or a test, it'll be less traumatic? What are the other sort of medical and surgical histories that maybe have been feeding into that autonomic nervous system separate from the trauma, like heavy periods or heavy cycles of menorrhagia is a term that you're bleeding almost like you're hemorrhaging every month. And women sometimes need to have blood transfusions because they have so much bleeding. Dysmenorrhea in Latin just means bad. So just noticing bad periods, and many of our veterans have that as well. A history of some type of cancer, cervical cancer, prostate cancer, colon cancer. You've had incisions, you've had radiation, you've had things inserted. The ultrasound, the vaginal ultrasound is probably about as horrible as we can get when we think about you're awake, there's no sort of getting ready for that. And if someone's having trouble with the muscles of their vagina, and then we take a large instrument and place it in there, you now have more symptoms, yet the test was coming back normal, and now you feel more symptomatic. So these are real things that happen to our patients and happened to our 37-year-old veteran. She'd also suffered an ectopic pregnancy, which required emergency surgery, which is quite frightening. There's usually blood loss, there's sometimes blood transfusions, and it's a pretty, it's like sort of a fire drill in the emergency room when this happens. And then she also had some IBS and gastric ulcers. So there's something called the visceral somatic reflex. The organs speak to the muscle through the spinal cord. So if you have an ulcer in your abdominal wall, it's going to send a message to the spinal cord, which is going to send a message back to your muscles of your abdomen and your diaphragm to sort of block up, to stop moving, to not make this area more uncomfortable. And so we have some of that underlying muscle tension as well. So you can imagine that she presented with abdominal and pelvic pain. The next word here is, again, Latin dyspareunia, means bad or painful pairing. We love the Latin phraseology in Western medicine. She was frequently urinating, really wasn't relaxing and filling her bladder given all this abdominal and pelvic muscle tension. And she had trouble relaxing to have a bowel movement and came in with constipation. Okay. So starting from the perspective of the MD, the physical medicine and rehabilitation provider, my role is to I'm not a gynecologist, I'm not a urologist, I'm a muscle, nerve, and joint doctor. I sometimes, use a couple of analogies. I'm sort of the container doctor. I have a colleague in St. Louis who says if the organ doctors are the fruit doctors, I'm the fruit basket person. This fruit basket has special capabilities of holding and then relaxing, right? So it's sort of a setup to really be turned on, and then it's our job when we go to sit down to go to the bathroom to let everything relax. So anyhow, thinking about that type of assessment, the history is really important, especially like in case of our veteran, just these years of childhood dysmenorrhea, ectopic pregnancy, military sexual trauma, IBS. It's a bit of a chicken and an egg, but they're all happening, and they're all happening together. I want to really honor this issue that she's having pain, so I want to be able to put my hands on her palpate muscles, and in a minute we'll show you a diagram that's from an old medical textbook, which is not how we do our work now. But before I would even lay hands on the patient, I'm going to be talking to the patient fully clothed. I'm going to be bringing out a model, if that's not too triggering, explaining where muscles begin, where they end, how they act, and why I would like to examine the muscles, and again, giving them that reminder at any moment we can discontinue the palpation of these painful muscles. We can start externally by palpating sort of some of these bony landmarks. Like right now I'm sitting on what are called my sits bones or my ischial tuberosities, where my hamstrings attach, as Carla just stood up and moved hers around to get some blood flow. Medial, or to the middle of these ischial tuberosities, is where we can feel the pelvic floor from the outside. I want to get a look at how much can the patient move, because very limited or constricted muscles will limit general motions, touching your toes or me moving somebody's hip. And then after, again, a conversation, a model, and being able to get the consent of the veteran, I might do an intravaginal and an intrarectal examination, which is to, again, after reviewing the origin, the insertion using a model, which looks like the pictures that Carla showed us, the reasoning of what are the names of the muscles and what do they do, and how do I believe they might be part of painful sexual function, leaking of urine, difficulty relaxing to have a bowel movement. And then from there, I will have an assessment and then a medical diagnosis and a plan, which is really the way all physicians behave, and why we're in the roles that we're in. And as we say once and over again, in all capitals, informed and ongoing consent throughout this is non-negotiable, and offering to have somebody else, a chaperone in the room, if somebody has someone that is there with them. So this is actually found in one of the old medical textbooks, which it's a little bit triggering, so again, apologies to folks, but this was really what was shown in a textbook, which is so inappropriate in so many ways, that we would ever have an undressed patient, that we would ever have her, in this case, looking up and not relaxing and feeling so on edge and needing to actually keep an eye on what's happening. So again, we offer a chaperone. We ask, how have previous exams gone? Because many times on medical exams, the more urgent the situation, imagine when she had her ectopic and she was bleeding and her blood pressure was dropping, and what was that actual physical experience for you? Explaining what we can do using the model, and offering in, do you have consent for us to do this today? Sometimes we don't do that at all on the first exam, which is perfectly appropriate and is certainly an option for folks. And validating that, this can be provocative, so why don't you do your own self-calming techniques to kind of get us started, and then we can keep checking in with me. And if something happens like a flashback, this happens, and we'll take a break. And, obviously when it's a veteran here for our Excellent Road Home program, then they have their behavioral health care that same day and can sort of work through that. Patients are always positioned as comfortably as possible. We don't always get to examine everyone in the same way, given other reasons that they're more uncomfortable laying on their back or their side, and we're completely open to that. And obviously draping the patient and understanding why we sometimes need to move the drape to see things. If they have scars on their abdominal wall, as an example, as somebody here who had an ectopic and an urgent surgery, we want to take a look at those scars and feel those scars. At any moment, it's with a verbal or a hand cue, this examination can be ended. I would say, as a general sense, it is oftentimes such a relief for the veteran to say, you heard me, and now you want to examine me and figure out what is causing this pain and why I can't relax. And it comes with this, sometimes tears, and oftentimes just this feeling of such gratitude. But if that's not the case, we can certainly, make the first exam a conversation, fully dressed, very brief, if things are triggering. So I'm kind of giving you the sort of the full history and physical, so we can really then map out a medical plan. Okay, thanks. Okay, so just quickly, what did we find? Basically, a patient who was kind of bent over, crossing the legs, hunched posture, and if that alone doesn't make you think, well, these muscles are going to be in this shortened condition, even because if you're always sitting forward, your abdominal wall is shortened, your muscles of your pelvic floor, your legs are crossed. There's not a feeling of relaxation and good blood flow. Looking at range of motion, she was able to touch her toes and arch backward, but when she went into that arching backward, she had some abdominal pain because the muscles that originate in her rib cage and attach to her pubic bone were now being put in a stretched position. So that was my first indication. Yep, I thought she had abdominal muscle tension, and that would be a finding on the movement exam. When I watched her go from standing to sit on the bed to lay on her side, lots of pain. And every time, even almost before she went to sit up, when she just started to fire her muscle, there was discomfort. Okay, and again, watching that and acknowledging that that would be the case if you had a lot of muscle tension felt really helpful and powerful to her. Tender muscles along the abdominal wall superficially as well as deeper. There'll be no anatomy test, but the iliopsoas is a great big, I call it the suspenders of your trunk. They come off of your spine, they attach into your femur and send the psoas minor, we send a whole strap of muscle right into your pelvic floor. So obviously all of that is all working together to make it hard for her to actually relax her pelvic floor, which also I found on her internal exam that there was tight and tender muscles more to one side than the other. And then in the middle of all that, I want to make sure I do a good neurological exam because many of our veterans have other types of injuries or may have some other lumbar disc related issues. So that's my job as this type of medical provider to be sure we haven't missed another type of indication for trouble with urinating or defecating that comes from the neurological system. Okay, that was a whole lot that I threw out at Ed. Does anybody want me to clarify anything at this moment? Happy to do so. Otherwise, we will tell you what are the things that I asked the veteran to do, and then Carla is going to go from there and talk about the physical therapy part. So this sort of picture on the right is probably something that some of our veterans do already. I know when I've been to mindfulness meditation classes, some folks like to meditate in this position. I've heard it called the astronaut. I've heard it called the 90-90. But really in this position, we really take a lot of pressure off of the pelvic floor muscles and those vertical muscles of the abdominal wall and the spine. And it's a really nice place to start to relax your pelvic floor. You could also have a heating pad on your belly, which is a nice relaxer of the superficial muscles and a nice cue when you're trying to work on how to take a nice deep breath down into your belly or diaphragmatic breath. Warm water in a bathtub or a pool can also help bring rest and relaxation to these muscles. Yoga, I always say, probably restorative or entry-level yoga is another community exercise program that really focuses on intentional breathing and relaxation. There's different pillows and blocks that you can really use if you have some orthopedic reasons why you can't be in certain positions. Doing your meditation in this position, Carla calls it as the Z lying position. So whatever we call it, this is a good thing to do. We have acupuncture at Road Home, which is fantastic, and many communities and other programs, Wounded Warrior programs and others for veterans also have acupuncture, which really gets to that whole kind of organ system energy flow. Sometimes I get into medication management, not so much at the Road Home because I only see folks usually once. But if you have an ongoing relationship with your client and they get medical care near you, there's also some medications that can be thought about. Some to help relax your bladder, et cetera, depending on the specialist that you might see. And then, of course, I have the great privilege to have this coordinated care with behavioral health providers. Okay, I think I'm going to mute, and I'm going to have Carla talk about what she does. Okay, you're up, Carla.
Perfect. So I know Dr. Dugan took a pause and said, who has questions, but I will reiterate that. You don't have to put them in the chat. You can put them in the chat. You can unmute and ask a question if you'd like. So I want to give a little time for that. All right. Please interrupt me. I appreciate questions, but I'll talk to you about, what we as pelvic floor PTs do. There's going to be a lot of overlap with what Dr. Dugan just shared, and that's by design. We're kind of like confirming and then going forward with that diagnosis of pelvic floor dysfunction. I did link here Dr. Dugan mentioned that many VAs now have pelvic floor PTs, and that's wonderful, but not all do, and maybe not everyone wants to go to the VA for this. There are other pelvic floor PTs. We are growing a lot. And so I provided this link here, and I can put it in the chat too if that's better for everybody. All right, so I'm going to breeze through assessment. It's very similar to what Dr. Dugan mentioned. We are also giving the same amount of time and education about what these muscles do. And if the patient consents and it's appropriate, we'll do an intravaginal and or intrarectal examination, because that is the gold standard way for us to assess these muscles. We can assess externally, but there's a lot of other things in the way. So I would just say that it's like a little less reliable. And so if it's appropriate and the patient is consenting, I think it's the best thing to do is to do an intrapelvic examination so that we could really figure out, like, what are you doing with these muscles, and are they the cause of some of your symptoms, right? And then, of course, we're educating about like our findings, how that relates to their symptoms. And we put this on the slide intentionally repeatedly because informed consent is one thing, but I really think that everybody deserves ongoing consent. So what I say to my patients is, you know, I'll maybe ask about a trauma history or, you know, whatnot. And I say, even whether you've had trauma or not, this can be a sensitive area that I'm examining, right? And I usually make a little joke because I'm a little jokey, and I say, I don't read minds yet. So I need this to be a conversation between you, my patient, and myself. And so what that means is I am going to say everything I'm doing. I don't like surprises in my treatment room. I don't think you would either. And so I say, I am moving my hands down your leg. I am now touching your sit bones. So I call that monologuing. And I tell them I'm doing this so that A, you're not surprised, because, you know, for many of us who have experienced trauma or who have PTSD, a surprise can be triggering, even if it's not a negative surprise, right? So giving a lot of forewarning. And I also say the other reason I do that is so that it's a conversation. I'm saying this, that's your perfect time to say, hang on a second, or wait, or no, any of these are appropriate things, or why are you doing that again? You know, any of that is good. This is a conversation, not a one-directional lecture, right? Similarly, I am opening up questions again. All right. Okay, so I think this is important to say, just to back up a little bit, that pelvic floor PT as a whole should be tailored to the patient. It should be individualized to the patient and their symptoms, okay? We have the fortune of, you know, usually being able to see our patients typically weekly. That may depend on scheduling, but we see people more frequently maybe than the medical team can see them. Because again, our job is then to teach them what to do, is how I think about it. So I am helping with self-management, encouraging independence, helping them to learn how to use this part of their body differently to reduce their symptoms. And this should always include shared decision-making. So I'm coming to the table with, you know, here's what I know we can do, or here's what I think we can do. What do you think we should do? And then we kind of negotiate between and say, okay, this is our shared plan going forward. I think that's super, super important when you're talking about consent. And in this context of MST, or again, any type of trauma or PTSD. Something that grinds my gears a little is we all document informed consent was obtained. And I always kind of question that about, you know, well, how was it obtained? How do you know that it was obtained? How do you know that it was informed? You know, so I think reiterating or reinforcing what Dr. Dugan said about like having multiple conversations and having lots of space and touch points for, I'm checking in again, I'm checking in again. I think that's really, really important, especially in the context of what I do. So these may be familiar concepts to some of you about, graded exposure. So a lot of my patients have hypersensitivity to touch, or a fear of using a certain part of their body. In the cases of, my patients who I'm seeing for sexual dysfunction, they may have a fear of, for people who have vaginas, for example, or who engage in anal intercourse, they may have a fear of penetration, or it may be painful to penetrate. And so we're working on graded exposure to penetration, for example, okay? And that goes along with desensitization. So how can we nudge your nervous system so that you can do a little more without having a negative response, right? That's kind of the goal. So everything that I'm going to say kind of follows from that previous slide. We do a lot of re-education, retraining. So I am teaching you, this is what I want your pelvic floor muscles to do. Here's what you're currently doing. Here's how we're going to do that. The purpose of my finger in the intrapelvic exam is, one, to assess, to determine what is going on, but also to give you or the patient feedback, because you can't see these muscles. So there's a real reason for us to touch the muscles that may hurt or may be implicated in your care. And then we also use things like biofeedback to give you a visual representation. We're using tons of verbal cues. So again, I think of myself as a teacher or a coach to my patients. It's just in this region. Like I mentioned, we're doing a lot of graded exposure. So dilators or trainers are these devices that basically you can insert into the vagina or the anus, and that helps you to maybe start with smaller sizes that are less fearful, and then we can graduate up a size. I encourage my patients to touch their own bodies. I think that is very empowering and gives them more control. Anything that I can do to give them back their power, I think, is really, really, really critical in these cases. Dr. Dugan mentioned, a lot of education. We're doing bladder diaries. How often are you peeing? And we're providing education about, like, literally how to sit on the toilet, how frequently you should go to the bathroom. One of my favorite phrases is, in every 3, you should pee. Which means every 2 to 4 hours to go to the bathroom is normal while you're awake. All right, so again, I talked about graded exposure. That doesn't just include like this insertional activity or the pelvic floor specific, but also a lot of my patients just aren't moving. And so getting them back to moving at all, I think, is really, really important. Starting a walking program, having them work on breathing, like in that Z-lying position we talked about. Now I'm like, oh, I should have put another picture. So I'm just going to use myself here, but I will show you that the pelvic floor muscles here on the bottom are connected to the abdominal wall, connected to the diaphragm here. And so as we breathe in, our lungs are filling, the diaphragm's lowering, the pelvic floor should be lowering or relaxing, right? So we're trying to kind of reestablish that normal physiological motion that's usually lost or not present in most of our patients at the start of care. All right, so with our patient case, I would just apply these things. It sounds like she has overactive pelvic floor dysfunction. And so I would likely first assess and then tell her as I'm touching on the muscles, okay, this is painful. Here's what I want you to do. I want you to take an inhale, fill your belly as you are breathing all the way down to your vagina or anus. It'll feel almost like you're pushing out maybe a little bit, and that's good. That's a pelvic floor drop, right? Or a reverse Kegel, sometimes we'll call that. So if you want, you can all try that right now too. So you inhale, fill your belly, and feel, maybe if you're sitting, do you feel more pressure on the chair in the area of your perineum? And then I would give her passive stretching in the pelvic floor muscles, maybe passive massage, and then I would give her a lot of global stretching and movement. And Dr. Dugan, we're going to end talking about interdisciplinary care, and I want to reinforce that this goes all directions. So take it away.
Thanks, Carla. Let's go to the next slide. And obviously, the work that's being done in behavioral health, the work that's being done in relationship management and family education, it's all just so amazing when we wrap around that person with pelvic floor dysfunction. And I guess you would sort of put myself and maybe psychiatrist that's also working on medications to be on the medical team quickly, you know, a little walk down antidepressant medications, which can cause sexual dysfunction on their own, pain medications, which can cause constipation on their own. So there's ways that the medical team is helping, in the ways that we're adding additional barriers, perhaps to normal defecation, normal urination. But, you know, balancing mental health benefits of the meds versus the side effects is also important. And if we can find a medication that's successful in mental health and least side effects for the abdominal and pelvic health, that would be a great thing for us to be doing, of course. Carla did a lovely job talking about pelvic floor physical therapy, which really is happening once a week, but really starts to restructure people's behavior, their focus on education. I would just say quickly that the handoff after physical therapy is a really crucial moment where we oftentimes lose our human behavior. As humans, it's happy to be directed. We've got accountability when we come in next week to the appointment. Did you do your homework? And so really handing people off to regular program. Maybe it is joining a yoga class so that there's sort of a place to go if in fact they want to be around folks, and maybe it's just dedicating a certain time of the week. You're not coming into therapy anymore, but that's your time to do your work at home. But it is, I would say, as a system, I really wish we had more coverage in health insurance for trainers and for group projects. I mean, I heard today I had a patient who was talking about the Lance Armstrong program at the Y, where he kept being able to do yoga, which was like, thank you for that, right? So what are some of the things? Warm water programs from the Arthritis Foundation, maybe we need to kind of cross-reference. And then lastly, of course, our mental health providers. And I hope you got the idea that skills that folks are learning from the mental health providers, we bring into the pelvic floor treatment. And in fact, a couple of years ago, we did a study when one of our other mental health providers was here, where we really educated physical therapy providers in the curriculum that the veterans were getting, so that we could, you know, use similar language and reinforce this kind of attention to the fight or flight or freeze happening, and what people could do in the moment to change some of that. So yeah, this doesn't happen on its own, and it happens in an interdisciplinary way. So I just wanted to call that up to the surface as well. Carla, anything to add there?
No, but I think we do have some questions, and I think it's really important that we leave time for questions. We do have references, of course, but I think the most important thing is your question. So Jennifer asked, is the work you do with pelvic floor physical therapy happening while an individual is in the Road Home IOP? So I will say I am not working in the Road Home program, but Dr. Dugan, maybe you can answer this question.
Yeah, the focus of the Road Home program right now is really mental and behavioral health. And I really, again, it's such a privilege to work with my teammates there. Given the number of folks that come and that focus on individual and group and arts and other things, I usually just see people once, and then I try to coach them up for how they're going to get home and advocate for themselves. And that's kind of why I know now I'm meeting veterans who have already had a round of pelvic therapy at their VA, which is like, yay! You know, this is something in a decade that the needle is moving. But really, the Road Home program doesn't really have the space at this point to really include care. But hopefully things like the the Z-lying or the breathing is something they can bring right back into their behavioral health work.
But maybe in the future, this is a good idea. Maybe something we can strive for too. Daphne said a lot of the VA medical center does not take the holistic approach. I am sorry to hear that. I think that's why programs like the Road Home program are available, you know, because it's specifically for that purpose, I think. Okay, so Monica said, how might I, as an LCSW social worker, effectively advocate for and support a veteran client receiving care from a referring provider who demonstrates potential bias or lack of clinical buy-in regarding pelvic floor dysfunction, particularly when such bias may limit access to appropriate referrals, evidence-based treatment, or interdisciplinary care when appropriate. So I'm interpreting this question, and please correct me if I'm wrong, that you as their social worker are saying, I think you have pelvic floor dysfunction. I think you need to go see somebody for that, or go get pelvic floor PT, go to your physician, get a referral. And maybe the physician is not on board with that. I will say, and Dr. Dugan, please answer this too, but it depends on the state that you're in, of course. PT is direct access in a lot of states, including Illinois. Now, that wouldn't be the case for the VA system, and may depend on the patient's insurance. But sometimes you can go directly to a PT or a pelvic PT. And then I guess my thought would be maybe finding another doctor who would support it would be my way around that. I'm very curious why someone wouldn't support a referral to pelvic floor PT. And we may never know, but I really am curious. Dr. Dugan?
Yeah, I mean, I think we might live in a bubble because we know this area and we treat it, and we always look at our veterans through that lens. I would say, as a medical education provider, I've been here at Rush University Medical Center for 22 years. I'm typically in the anatomy lab once a year, trying to expose all medical students to the muscles, to their function, to their dysfunctions, to pathways, if we do clinical correlations to a pathway that would cause dysfunction. But people sort of self-select into specialties, and many times, I'll give surgery as an example, they would like to find a problem, fix it, and then they're done. And we lean into a lifetime or a short or longer relationship with patients. So it's partly on us to train people to understand. I would say oftentimes I write a long note back to a provider and might even include in the person who didn't have the belief in or knowledge of, to start to educate in our team, because sometimes team members just don't get it. So I've heard this before, and I also want to lift up that Monica mentioned she really benefited after childbirth, which was sort of the birth of pelvic therapy was really childbirth, and the amazing things that the vagina does to deliver the head and shoulders of an infant. Carla, I'm just looking at the time. Let's do Marin's question next.
I would love to do Marin's question. This is a great question. So Marin asked, do you have particular questions that you think might be good to ask to help discern the expertise and level of commitment to trauma-informed pelvic floor PT? So I think basically you're saying, I want to make sure that the pelvic floor PT I'm sending my patient to is good for them. And I agree wholeheartedly. I wish I could say everyone in my profession was excellent at this. I think we are getting much better. Here would be my suggestions is, one, empower the patient that you're sending to pelvic floor PT to go with their gut. If they go to that first meeting and they're just feeling something's off, they don't have to come back. And I think that that's really important. People feel very indebted to loyal or just with our healthcare system. I think they feel like, well, this is it, or this is the only person I can see. And I don't know that that's always true. And so I think encouraging them to, tell you maybe how they felt about it. I have had patients who will say to me, or I have asked, would you be okay with me contacting your mental health provider? And the reason I would do that, I'm like, I don't need to know anything that you don't want me to know, but it's so that I can ask them, are there words I can use, techniques I can do, or things I should avoid talking about? It just helps me kind of get a better sense. So I think if you as the mental health provider maybe are referring, if the PT is willing to talk to you and makes that time, I think that's a pretty good bet that they're going to be trauma informed and appreciate that care. But I think also that the patient can ask, how much do you work with people with trauma? What's your experience level? What kind of trainings have you done? And if a PT or any provider, frankly, gets defensive or something about that, I think that might be your answer. I appreciate when patients ask me those kinds of questions, actually. So, and then, okay, really quickly, Daphne, you said, what additional signs or symptoms related to MST should patients and their care teams monitor to ensure timely and appropriate treatment? I think, again, any of those like bladder, bowel symptoms, and then sexual functioning. Yeah, Dr. Dugan, I mean, that's kind of the broad strokes.
Yeah, and Daphne, I would just say, if you have an idea that that's an issue, you can always send folks. I saw someone today that had an orthopedic thing. The other provider was thinking, is this pelvic floor? I mean, the best thing is the person comes in, there's nothing significant yet. There's always something, the way people carry themselves, the way they may or not be using yoga and breathing. So I would just say, when in doubt, you have folks come in. We can think about, preventatively as well, but bowel, bladder, sexual dysfunction, pain with penetration, all these things can all be harbingers of too much tension in the pelvic floor. This is a great group this year. We haven't had this many people before, so it makes me hopeful, just like I'm hopeful that we have this opportunity through the Wounded Warriors here at Rush Road Home Programs to talk about pelvic health. There's pelvic therapists in VAs, not just MST coordinators, that you all are here, and really happy to spread the word. And please, you would all spread the word to your veterans and to your colleagues, and we can make the world a better place for pelvic floors all over the country and the world. Thanks so much.
And with that, we included our contacts on, so if you have a question or you want to reach out, feel free. We put them on there to be used.
And thanks, Carla. Thanks for being here with me this year.
Thank you.
Mariana and everybody else Joseph, who all made this happen.
Thank you guys for facilitating this. This was wonderful.
And thank you all for a great talk. There's a lot of thank yous coming through in the chat as well.
Feels good.
And we hope that you all join us for our next talk as well next week.
Oh, yeah, that looks very interesting. Thank you.
All right. Have a good day, everyone. Bye.